So, good evening, everyone. I welcome you all for to the today's class. Um, Malavika will be presenting on fluids and electrolytes for today. Malavika, start off.
Yes. Good evening, everyone. Topic for today is fluid and electrolytes. Starting with the total body water. Total body water refers to the total amount of water in the human body expressed as percentage of body weight. It is approximately 60% of the body weight in adults. It varies with age, sex, and body composition. Children have a more body water because of the higher proportion of lean muscle mass and lesser adipose tissue. Females, compared to males, have more fat and hence less water. And in elderly, there is a decrease in muscle mass and hence they are at a higher risk of risk for dehydration and electrolyte imbalance. Among the total body mass, it is the total body water comprises of 60% of the total body weight, and the total body water is divided into the intracellular fluid and the extracellular fluid. The two-third or the 40% of the body weight is the intracellular fluid, and one-third or the 20% of the body weight is the extracellular fluid. And in the extracellular fluid, it is further divided into the interstitial fluid and the plasma. The intracellular fluid is what is found inside the cells and are made up of protein, water, electrolytes, and solutes. The interstitial fluid, it refers to the fluid which is outside of the blood vessels and is between the cells, and it acts as an exchange medium. The plasma or the intravascular fluid is the liquid component of the blood in which the blood cells are suspended and is responsible for maintaining the circulation. And there is also 1% transcellular fluid, which is the fluid in areas such as CSF, cerebrospinal space, the synovial fluid, the intrapleural fluid. The what?
Malavika,
Sir.
actually, I think it is a problem with all people from Kerala and Tamil Nadu. They keep saying percentage. It's not percentage, it's percent. That's all.
Okay, sir.
Percentage is a noun form. You don't keep on using percentage. You have to
Okay,
just say
sir.
80%, not 80 percentage.
Okay, sir.
80%, 70%, 60%. Percentage is when you are using it as a noun form. Okay, so but I have seen that all people from Tamil Nadu, Kerala, it's not a racist comment or anything. It's probably how they are taught, but that's wrong. You have to say
Yes, sir.
percent, not percentage. Okay, carry on.
Okay, okay, sir. Coming to the fluid and the electrolyte regulation, the water balance is regulated by several mechanisms, including the antidiuretic hormone, the thirst, and the renin-angiotensin-aldosterone system. The fluid intake is regulated by the thirst. When the fluid is lost, the serum sodium level will increase in the intravascular space, and this is the serum osmolality. That is a measure of the concentration of dissolved solutes in the blood. These osmoreceptors, which are present in the hypothalamus, will sense this increased serum osmolality levels and will trigger the release of the antidiuretic hormones and thereby acting on the kidneys to retain the fluid. These osmoreceptors will also produce the feeling of thirst to stimulate the increased fluid intake. And also, when there is decreased blood pressure, which can be because of some fluid loss, the juxtaglomerular cells in the kidney will secrete renin into the bloodstream. And the renin acts on the angiotensinogen, which is released by the liver, and it converts into angiotensin 1, which is then converted into the angiotensin 2 by the angiotensin converting enzyme. And this angiotensin 2 will cause vasoconstriction, thereby increasing the blood flow to the vital organs. And it also stimulates the adrenal cortex to release aldosterone. Aldosterone is a steroid hormone which will trigger the which will cause the increased sodium reabsorption from the kidneys and subsequently the increasing serum osmolality in the bloodstream. The water steady state refers to the dynamic equilibrium between the water intake and water loss, thus maintaining a constant total body water and plasma osmolality under normal physiological conditions. The water intake is mainly through the food or the drink, which corresponds to 2.2 liters per day, and the metabolism, which corresponds to zero point 0.3 liters, and a total of water intake is 2.5 liters per day. And the water out is in the form of urine, which corresponds to 1.5 liters per day, and the insensible water loss through the skin and lungs, which is zero point 0.9 liters per day, and through the feces, 1.1 liters per day, which is also 2.5 liters. Thus, the water ingested is equal to the water excreted. So this is a table showing the normal ionic composition of the body fluids. So in the plasma, it is the sodium, which is the predominant cation, and chloride being the predominant anion. In the interstitial fluid, the same sodium is the predominant one and chloride. And intracellularly, it is the potassium, which is more predominant cation, and phosphate being the predominant anion. So the fluid and the electrolyte disorders can be classified based on the volume, concentration, and composition. So the volume changes refers to the alterations in the effective circulating volume, which is mainly within the extracellular fluid, extracellular compartment. So it can be hypovolemia or hypervolemia. And this is the most critical category because it is the one which directly affects the tissue perfusion and the organ function and is the primary cause of shock in surgical patients. And concentration changes are determined by the serum sodium levels, which will reflect the plasma osmolality. It can be hypernatremia or hyponatremia, and these changes are particularly important for the central nervous system because the rapid shifts can lead to seizures, coma, and cerebral edema. And the composition changes are the changes in the specific electrolytes like potassium, calcium, and magnesium, which will be dealt in detail. So the fluid volume changes, the volume excess or the hypervolemia. It refers to the increase in the extracellular fluid volume leading to the fluid overload. The causes can be because of the iatrogenic excessive IV fluid intake and can be secondary to renal dysfunction, congestive heart failure, and cirrhosis. The signs and symptoms are generalized symptoms like weight gain, peripheral edema, and cardiac symptoms like increased cardiac output, increased central venous pressure, distended neck veins, pulmonary edema, and bowel edema. So here there is a retention of the sodium and water, which will lead to the expansion of the extracellular compartment, and the management mainly includes the fluid restrictions, the using of the diuretics, and the treating of the underlying causes. Uh,
Malavika, what is the
yes,
lesson for you guys? Go back to the previous slide.
yes, sir.
What is the lesson for you guys who prescribe fluids and during surgery?
Um, sir, when the patient starts to, after this surgery, if the patient starts taking orally, we have to stop the IV fluid. The excessive IV fluid intake is not required.
See, I think even the anesthetists need to know about it. I think basically the trend has gone from giving excessive fluids to what is called as obligatory fluid restriction. So, you would rather give less fluids than more. Or in patients where fluid is required, you do what is called as goal directed therapy. You give them fluid based on certain goals you set, that is mean arterial pressure, central venous pressure if you have a central line, or if you have esophageal Doppler, or previously we used to put what is called a Swan's-Ganz catheter, which nowadays nobody uses. So you need to know what is pulmonary capillary wedge pressure, and urine output of course is one of them. And then looking at the blood loss and how long the surgery is going to take, because there will be insensible losses when the abdomen is open, or if for example patients with burns where there is large burns area where there can be loss of fluid. So take all that into consideration and what is called as goal directed therapy. So when you guys prescribe IV fluids, you only write as much as is required depending on how much the patient is likely to take orally, and then monitor the urine output. And what you also have to look at is the first 24 hours there will be ADH secretion, so there will be this one retention of fluids in terms of, so urine output, you don't have to go for 1500 or 2000 ml of urine. You can, 0.5 ml per kg per day will be sufficient. And make sure that you only prescribe maintenance fluids, or at the most what is called, usually the rule of the thumb is 25 ml per kg per day. So that should be the, so don't prescribe excessive fluids, so that you whatever you have basically said about edema, pulmonary edema in the legs, and also bowel edema. So pulmonary edema will cause patients to become dyspneic and they will not breathe properly. Then edema in the legs will prevent them from walking, so they can then more prone for developing deep vein thrombosis. And bowel edema will cause ileus, so that the bowel doesn't function. So there are a lot of things which causes, the problems for the patients in the post operative period. So excessive fluid, you would rather err on the side of giving them less, unless the urine output drops or the blood pressure drops, and then you can actually respond to it. So these are very important points that you need to remember whenever you prescribe fluids, because you are the guys who are in the front line, and you also have to, anesthetists have to be told about this. They would just keep putting up fluids and looking at their newspapers or the this one their telephones, and they don't monitor these things. But those days have changed now, but still obligatory underhydration is the most important thing. Okay, carry on.
Coming to hypovolemia. Hypovolemia refers to the decrease in the extracellular fluid volume, leading to a reduced circulating blood volume. It can be because of the loss of GI fluids because of vomiting, diarrhea, hemorrhage, the loss into third spaces because of peritonitis, pancreatitis, intestinal obstruction, because of burn, the renal losses. The signs and symptoms include the weight loss, decreased skin turgor, cardiac manifestations like tachycardia, hypotension, collapsed neck veins, and renal features like oliguria, azotemia, and GI feature like ileus. So here there is a loss of both sodium and water. So the serum sodium may be normal, high, or low depending on the cause. And the management mainly involves a rapid intravascular volume replacement, usually with isotonic crystalloids like normal saline or ringer lactate. The volume control is sensed by both osmoreceptors and the baroreceptors. These osmoreceptors are
No,
the
yeah, are you going to give us this one explanation about how do you give fluids and all that
yes, sir.
later?
Yes, sir.
Later?
Yes, sir.
Yeah, okay.
Yes.
Yeah.
Uh, Osmoreceptors are the specialized sensors that detect even small changes in the fluid osmolality and drive changes in thirst and diuresis through the kidneys. Baroreceptors will modulate the volume in response to the changes in pressure through the pressure sensors which are present in the aortic arch and the carotid sinuses. And these baroreceptor responses are both neural and hormonal. Neural through the sympathetic and the parasympathetic pathways, and hormonal through the substances like renin-angiotensin, aldosterone, and atrial natriuretic peptide. And the final goal is to restore the circulating volume and to maintain the perfusion. So this is a table showing the normal values of all electrolytes. I'll be dealing with every electrolyte in detail. Mm. Sodium. The normal sodium level is 136 to 144 milliequivalents per liter. It is hyponatremia when it is less than 135 milliequivalents. So based on the severity, it can be mild, moderate, or severe. Mild is when the level is 130 to 134. Moderate is between 125 to 129, and severe is when it is less than 125. And based on the duration, it can be acute or chronic. Acute is less than 48 hours, and chronic is more than 48 hours. And based on the serum osmolality, it can be hypotonic, iso, or hypertonic. So the main manifestations are CNS manifestations like headache, confusion, hyperactive or hypoactive deep tendon reflexes, seizures, coma, musculoskeletal symptoms like weakness, fatigue, muscle cramps, GI symptoms like anorexia, nausea, vomiting, watery diarrhea, serious symptoms like hypertension and bradycardia, renal symptoms like oliguria. So coming to the etiology, it can be hypovolemic, euvolemic, or hypervolemic. Hypovolemic is because when there is a loss of sodium more than that of water. And the causes can be GI losses like vomiting, diarrhea, nasogastric suction, fluid losses because of burns, third spacing because of peritonitis, pancreatitis, obstruction, renal causes because of renal causes, diuretics or cerebral salt wasting syndrome, euvolemic hyponatremia because of the post-operative ADH secretion, where here the total body sodium is normal. There is a increase in the total body water. So it can be because of the postoperative ADH secretion, water intoxication, excess of the hypotonic fluids, SAADH, CNS injuries, etc. Hypervolemic hyponatremia is because here the total body sodium and the water both will increase, but the increase in water is more. So it can be because of congestive heart failure, cirrhosis, renal failure, nephrotic syndrome, fluid overload from restriction, etc.
So that is called dilutional hyponatremia.
Hyponatremia, yes, sir. So the management of hyponatremia, it mainly depends on the symptoms, duration, and the volume status. So mainly it is to restrict the fluid intake to 800 to 1000 ml per day and to treat the underlying cause. In cases of severe symptomatic hyponatremia, when the sodium levels are less than 120, we can use 3% hypertonic saline. So this is given 100 ml, 3% saline over 10 minutes, and it can be repeated up to 3 times if the symptoms persist. It raises the sodium by 4 to 6 milliequivalents per liter initially, and this reduces the risk of brain herniation. The sodium deficit can be calculated by the formula, the desired sodium minus the current sodium level into the total body water. And in cases of hypovolemic hyponatremia, we can use the normal saline 0.9% because it will suppress the ADH and thus improving the sodium level. And the rate of correction should be maintained, like it should be less than 8 milliequivalents per liter in the 24 hours or less than 18 milliequivalents per liter in the 48 hours. The rapid correction can cause osmotic demyelination syndrome, where the features include dysarthria, dysphagia, quadriparesis, etc. Coming to hypernatremia, hypernatremia is when the sodium levels are more than 145 milliequivalents per liter. The manifestations include CNS manifestations like restlessness, ataxia, lethargy, irritability, delirium, coma, musculoskeletal system weakness. Uh, there can be dry, sticky mucous membrane, swollen tongue, decreased saliva and tears. Serious symptoms like tachycardia, hypertension, syncope, and renal symptoms like oliguria. Here it can be because of hypervolemic, euvolemic, or hypovolemic. Hypervolemic is because of the excess sodium gain relative to the water. It because of the uh, hypertonic saline infusion or because of sodium bicarb administration, Cushing syndrome. Euvolemic can be because of the pure water loss without any significant sodium loss, which can be seen in diabetes insipidus, diuretic use, renal diseases. Hypovolemic because of the water can be through the renal loss, through the water loss through the kidneys, and non-renal loss, the water loss through the GI tract or the skin through because of diarrhea, vomiting, fever, etc. So the management is to identify and treat the underlying cause. So in a hemodynamically unstable patient, the first priority is to maintain the circulation. So we have to give 0.9% normal saline. Here we restore the perfusion even though the sodium is high. We will start with normal saline because it is a shock which will kill the patient faster than the hypernatremia. And the free water deficit can be corrected gradually with orally administered water and with 5% dextrose or 0.45% saline. In euvolemic hypernatremia, we can use desmopressin or thiazide diuretics. In hypervolemic hypernatremia, we can use dextrose 5% with loop diuretics. And the correction of the sodium should be no more than 10 milliequivalents per 24 hours because in rapid correction, the brain adapts to the hypernatremia, and because of the rapid dilution, the water will enter into the brain and will cause cerebral edema, where the features will include seizures, raised ICP. Next. Coming to potassium, the normal value of potassium is between 3.7 to 5.1 milliequivalents per liter, and hyperkalemia is when the level is more than 5.5 milliequivalents per liter. So the main manifestation of potassium is the cardiovascular symptoms like arrhythmia and cardiac arrest. This is because when the potassium level increase, the resting membrane potential becomes less negative and thereby increasing the excitability. So it causes conduction blocks and arrhythmias. And the ECG features like peak T waves, flattened P waves, PR prolongation can be seen. GI symptoms like nausea, vomiting, colic, diarrhea, neuromuscular symptoms like weakness, paralysis, and respiratory failure. It can be because of the increased intake, because of the increased potassium supplementation, the oral or IV supplementation, or because of blood transfusions, increased release from cells because of the hemolysis, rhabdomyolysis, crush injuries, GI hemorrhages, or burn, and impaired excretion because of the potassium sparing diuretics like spironolactones, then ACE inhibitors, etc. The main management identify the underlying cause and calcium gluconate.
Wait, ma.
Sir,
What is the commonest cause for clinically significant hyperkalemia?
You will see that in commonly in our practice also many a times.
What is the commonest?
mm, sir, kidney
Chronic
injury,
kidney
sir.
disease. Chronic
Yes,
kidney disease.
yes, sir.
Patients who are on chronic renal failure or even acute renal failure, I think that is the
Yes, sir.
commonest cause for hyperkalemia. And these people come with sometimes potassium of 8 and all that. So
Yes, sir.
these people have a high tendency to cardiac arrest in systole, sorry, in diastole. So I think you have to be extremely careful and treating them.
And probably they will require urgent dialysis.
Dialysis, yeah.
Yes, sir. Coming to the management, calcium gluconate, 10% is calcium gluconate, 10 ml IV can be given over 2 to 5 minutes. They act within minutes. This does not reduce the potassium levels, it stabilizes the myocardium. And insulin with or without glucose, 10 units of regular insulin with
How does it
50
act?
ml of
How does
sir,
it act? Calcium gluconate.
calcium gluconate stabilizes the myocardium, sir.
No, no. How does it reduce hyperkalemia?
Uh, sir, it protect against arrhythmias.
Okay.
Mm. It doesn't reduce the potassium level, sir. It just
Huh.
stabilizes the myocardium.
Membrane stabilizing effect, it's called.
Yes,
Membrane
membrane stabilizing.
stabilizing. So, because of the instability due to hyperkalemia, there is potential for arrhythmias and arrest in diastole. So, the calcium will stabilize the membrane and reduce the effect of potassium in causing arrhythmias.
Sir.
So it's basically a cardioprotectant in cases of hyperkalemia.
Yes, sir.
Okay.
Um,
So it does not reduce. One more thing is it does not reduce
one
serum
thing is-
potassium levels. Okay.
yes,
Yeah.
sir.
Okay.
Um, Also, beta 2 agonist like salbutamol can shift the potassium into the cells, and diuretics and cation exchanges can remove the potassium from the body. And in renal failure, or in cases of severe hyperkalemia, hemodialysis can be done.
Salbutamol, how do you give?
Nebulization, sir.
Hmm.
No, but more importantly, you have to mention thiazide diuretics above the beta, this one, the salbutamol, because
Yes, sir.
Correct.
Okay, sir.
because the well, it I think because they are loop diuretics and it exchanges sodium preferentially, absorbs the sodium and excretes the potassium, and because of that, you will get rid of excessive potassium.
Yes, sir.
So the sodium potassium pump that is there in the loop of Henle
Mm.
will be activated by the thiazide diuretics, especially so what Lasix, that is furosemide. So I think you have to mention that before that. I think insulin with not without glucose. Usually always give insulin with glucose, because if you give it without glucose, the patient may go into hypoglycemia, which can add to the problem. So you always give it with glucose, and glucose also acts by pushing the potassium
Potassium into the cells.
into the cells.
Yes.
Okay, by acting on the NAK ATPase mechanism.
Yes.
So don't give wrong information. I don't know where you got this information from, but you have to give insulin with glucose.
Yes.
Okay, carry on.
Uh, Hypokalemia is when the potassium levels are less than 3.5 milliequivalents per liter. So the manifestations are GI manifestations like ileus, constipation, cardiovascular like cardiac arrest, neuromuscular like decreased reflexes, fatigue, weakness, and paralysis. The ECG changes can be prolonged PR interval, absent P wave or slightly peak P wave, prominent U wave. Uh, the etiology can be because of the inadequate intake, because of the dietary deficiency, or the potassium administering potassium-free IV fluids like normal saline, dextrose, and potassium deficient TPN, and excessive potassium excretion because of hyperaldosteronism, drugs like loop diuretics, thiazide diuretics, laxative abuse, and GI losses because of diarrhea, vomiting, NG suction, nasogastric suction. Management, you have to assess the severity and treat the underlying cause. The oral potassium intake, potassium chloride, 40 milliequivalents can be given. It can be given in the form of potassium chloride. It can be given in the form of port chlor and tablet portrate, which is a potassium citrate based. This and IV potassium chloride can be given for severe hypokalemia. In peripheral line, the maximum concentration is less than 40 milliequivalents per liter at the rate of less than or equal to 10 milliequivalents per hour. Because potassium, being a highly irritant, it can cause pain and thrombophlebitis and extravasation injury and causing necrosis. In central line, it can go up to 80 to 100 milliequivalents per liter at rate of 20 milliequivalents per hour in an ICU with a proper cardiac monitoring. And associated magnesemia, hypomagnesemia can occur, and also that also has to be corrected. Coming to calcium, the normal calcium level is 8.8 to 10.5 milligrams per deciliter, and the normal ionized calcium level is 4.5 to 5.5 milliequivalents per liter. And when the serum calcium is less than 8.5 or the ionized calcium less than 4.2, we call it as hypocalcemia. So the clinical manifestations include tetany, paresthesia, perioral or the extremities, the carpopedal spasm, the seizures, and the other manifestation like the chopstick sign, which is the when tapping on the facial nerve, there is twitching of the facial muscles, and the trousseau sign when there is spasm of the hand and wrist occurs, which when there is when the BP curve is inflated above the systolic blood pressure for 3 to 5 minutes. So the etiology can be because of the decreased parathyroid hormone, which is mainly after the post-thyroidectomy, post-parathyroidectomy, or radical neck surgeries. It can be because of nutritional vitamin D deficiencies, because of malabsorption, GI losses because of some pancreatic fistulas, uh, increased calcium loss because of massive blood transfusion, tumor lysis syndrome, acute pancreatitis, and associated other electrolyte disturbances, hypophosphatemia or hypomagnesemia, and some malignancy related because of the osteoblastic mets from the breast and the prostate, drugs like bisphosphonates, loop diuretics, and some in case of severe sepsis, burns, chronic renal failure. So the management, immediate management is the usage of 10 ml of 10% IV calcium gluconate over 10 minutes, followed by the IV infusion. 50 ml in 500 ml of NS or dextrose can be given slow infusion with continuous ECG monitoring. And oral calcium therapy, like with Shelcol, Caltrate, etc. And these are calcium carbonate preparations, and calcium citrate preparations like calcimax citrate can be used. And a combination of oral calcium and vitamin D like Shelcol HD, calcimax sport can be also be used. And for the associated hypomagnesemia,
Don't
IV magnesium.
some brand names in medical presentations.
Yes, sir.
Okay,
Okay,
just
sir. Okay, sir.
tell about the molecule. Yeah.
Okay, sir. Okay. And phosphate binders can also be used for correcting the underlying hypophosphatemia. Coming to hypercalcemia, it is when the calcium level is more than 10.5 or the ionized calcium more than 1.3. The clinical manifestations include the CNS manifestations like fatigue, lethargy, confusion, depression, impaired concentration, coma, GI system, GI manifestations like nausea, vomiting, constipation, abdominal pain, serious manifestations like erythemias, hypertension, muscle weakness, bone pain, can be polyuria, polydipsia, nephrolithiasis, skeletal system like osteoporosis, pathological fractures, and psychiatric manifestations like mood changes, irritability, and psychosis. Etiology can be because of parathormone dependent causes like primary hyperparathyroidism because of parathyroid adenoma or parathyroid hyperplasia. Malignancy related because of the PTH related peptide secretion, um, which is seen as a paraneoplastic syndrome of breast, lung, and renal cell carcinomas, and vitamin D related complications, vitamin D related like vitamin D intoxication in cases of granulomatous diseases like sarcoidosis, TB, endocrine disorders like hyperthyroidism, adrenal insufficiency, drug induced because of thiazide diuretics, usage of lithium, um, miscellaneous causes like immobilization.
One more important thing is excessive ingestion of vitamin D and and calcium. There are many people who keep on taking this without their knowledge. I have at least treated two people whose calcium was 16 and 15.6. They were taking calcium and vitamin D forever. So that is one of the things. So that is why whenever many of the patients, when you now look at it, all labs give vitamin D levels as less than 20. So and everybody will be put on the supplements. So whenever you put people on supplements, you have to warn them that you can't keep on taking them, keep taking calcium indefinitely. In between, give it a rest. And women who are postmenopausal, whom you start on vitamin D because they are prone to osteoporosis related to decreased, this one, what is that? Estrogen and progesterone. And such people, they are prone to developing osteoporosis. You can give them supplementation, but you have to be careful about it. One of the common causes for hypercalcemia is excessive intake, especially vitamin D and calcium. Okay, carry on.
So the management is the aggressive high dehydration. Normal saline can be given 200 to 300 ml per hour. Loop diuretics, 20 to 40 mg IV. It will increase the calcium excretion. Calcitonin, it can be given as an IM or a subcutaneous injection. It is short-lived but will act rapidly and it will decrease the calcium level. Bisphosphonate like zoledronic acid and pamendronate. Steroids can also be used in vitamin D mediated hypercalcemia. In severe hypercalcemic crisis, when the level is more than 14, hemodialysis can be used and parathyroidectomy in case of primary hyperparathyroidism. Hypomagnesemia, the normal magnesium level is 1.4 to 1.9 milligram per deciliter. And when less than 1.46, it is hypomagnesemia. And the clinical manifestations, the serious manifestation is the life-threatening erythema, the Torsades de Pointes, GI manifestations like nausea, vomiting, abdominal cramps, anorexia, neurological like psychosis, confusion, and neuromuscular like numbness, tingling, cramps, tetany, seizures, etc. So it can be because of the decreased intake due to malnutrition, chronic alcoholism, GI losses because of diarrhea, malabsorption because of the celiac disease or Crohn's disease, NG suctions, and renal losses because of the renal losses, and drugs cause like loop and thiazide diuretics, aminoglycosides, etc., and other causes like pancreatitis, refeeding syndrome, etc. So the management in a hemodynamically unstable patient, magnesium sulfate 1 to 2 gram IV can be given over 15 minutes. In a severe symptomatic but stable patient, magnesium sulfate 1 to 2 gram IV infused over 1 hour. And a stable patient without any emergency symptoms, the magnesium sulfate can be given 4 to 8 grams IV slowly over 12 to 24 hours. And in cases of Torsades, 2 gram IV stat magnesium sulfate is given. In asymptomatic patients, oral magnesium replacements with magnesium chloride and magnesium lactate sustained release formulations can be given, and the associated electrolyte disorders should also be corrected. Hypermagnesemia is when there is more than level is more than 2.4 milligrams per deciliter. The earliest clinical sign is the loss of the deep tendon reflexes. And the other manifestations like lethargy, drowsiness, confusion, coma, hypotension, bradycardia, heart block, respiratory depression, and in severe toxicity, it can lead to cardiac arrest. It can be because of the decreased renal excretion, excess magnesium intake, like in magnesium containing antacids or laxatives, or iatrogenically, we give magnesium sulfate in case of preeclampsia, and cellular release because of the tumor lysis or the rhabdomyolysis. And management in mild asymptomatic cases, we stop the magnesium intake and monitor the levels. Moderate symptoms, if we give IV fluids with loop diuretics, which will increase the magnesium excretion. And in severe toxicity, IV calcium gluconate can be used. And severe renal failure or in life-threatening levels, hemodialysis have to be done.
Likit,
Hypophosphate.
just a minute, ma'am. Likit,
Yes, sir.
which are the two electrolytes which have inverse relations? Just study that now.
Hello. Two.
Anybody else?
Mag-
Ainas,
Magnesium and calcium only, sir.
magnesium and calcium. So what happens if there is high calcium, magnesium levels dip, and similarly when there is high magnesium levels, calcium levels dip. So you have to treat that with infusion of the other so that you can reduce the effect of these. So
Yes.
they have an inverse relation. Okay, carry on.
Coming to phosphate levels, the normal is 2.4 to 4.5 milligram per deciliter. And when it is less than 2.5, we call it hypophosphatemia. The important clinical manifestations are CNS manifestations like seizures, delirium, fatigue, encephalopathy. It can cause hemolysis, thrombocytopenia. It can cause decreased myocardial contractility, causing arrhythmias and heart failure, and cause rickets, osteomalacia, growth retardation, and can also cause ILS, rhabdomyolysis, proximal myopathy, etc. It's mainly because of the decreased intake, because of malnutrition, alcoholism, starvation, and decreased intestinal absorption in case of malabsorption, vitamin E deficiencies, chronic diarrhea, increased renal losses because of the renal tubular defects or usage of diuretics, intracellular shift because of the refeeding syndrome, insulin therapy, and other causes like burns, sepsis, etc. So the management in mild to moderate levels, when it is more than 1.5 milligram per deciliter, or in case of asymptomatic, we can give oral replacement therapy, oral replacement with Nutrafos, which can be given 2 packets 6 hourly. And in severe cases, in less than 1.5 milligram per deciliter in symptomatic patient, IV sodium or potassium phosphate is given, and we have to monitor the calcium level because IV phosphate can cause hypocalcemia, and also the renal function also to be monitored. Hyperphosphatemia is when the levels are more than 4.5. The manifestations include neuromuscular manifestations like tetany, muscle cramps, paresthesia, and cardiovascular like arrhythmias, CNS irritability and seizures, and in chronic cases can cause vascular calcification and soft tissue calcification. Uh, it can be because of the decreased renal excretion because of CKD or AKI, increased intake because of the excess phosphate supplementation or because of the phosphate containing enema, cellular release because of the tumor lysis, rhabdomyolysis, hemolysis, endocrine causes like hypoparathyroidism, and other causes like vitamin D intoxication. So the management mainly is a dietary restriction, usage of the calcium-based binders and phosphate-based non-calcium binders like cebalum or lanthanum, etc. Sir, I'll continue the fluids also, sir.
Yeah.
So the fluids um, can be divided into crystalloids and colloids. So crystalloids is an aqueous solution which is composed of water and small solutes such as electrolytes and glucose, and it can be categorized based on whether they are hypotonic, isotonic, and hypertonic. So the isotonic ones are the 0.9% normal saline, ringer lactates, plasmolite A. Hypotonic are 0.45% NaCl and 5% dextrose. Hypertonic are 3% NaCl, 5% NaCl, and 7.5% percent. Colloids are uh, colloid solutions are large molecular weight particles such as some proteins or hydroxyethyl starches which are suspended in a crystalloid solution. It can be natural or synthetic. Natural is albumin, fresh frozen plasma. Synthetic is hydroxyethyl starch, gelatin, dextran, etc. So this is a table showing the composition of the normally available crystalloids. And this is of the colloids. Coming to normal saline. So normal saline is the most commonly used crystalloid in surgical practice, and it contains sodium and chloride of 154 milliequivalents per liter with a total osmolality of 308. So it is functionally isotonic with the plasma. So after the infusion, it will distribute entirely within the extracellular fluid compartment. Only about one-fourth of it remaining in the intravascular and the rest moving into the interstitial spaces. So that is why large volumes are often required for the effective resuscitation. So it's mainly used as an intravascular volume expander, making it more useful in cases like hypovolemic shock, trauma, perioperative fluid management, and also in case of hypovolemic hyponatremia. So, and it is also a preferred fluid for blood transfusion because it does not contain calcium, and so that it does not interfere with the anticoagulants in stored blood. And however, despite being called as normal, it is not physiologic. Because of the high chloride content, it can result in hyperchloremic metabolic acidosis when administered in large volumes. So the excess chloride can also cause the renal vasoconstriction and also reduce the GFR. And it can also result in fluid overload, pulmonary edema, and dilution coagulopathy if administered more. Ringer lactate is a balanced isotonic crystalloid because its electrolyte composition is more closely resembles that of plasma. So it contains sodium, potassium, calcium, and lactate with a total osmolality of 273 milliosmol per liter. So after the infusion, it also distributes within the extracellular compartment and only about one-fourth remaining in the intravascular, making it more effective for volume resuscitation in hypovolemia, trauma, burns, and perioperative fluid management. And here the ringer lactate contains lactate, which is metabolized in the liver to bicarbonate, thereby having an alkanizing effect, so to prevent the metabolic acidosis. And, and because of its more physiological chloride content, it does not causes hyperchloremic metabolic acidosis, which is seen with normal saline, and it has better renal perfusion also. So the limitation is that it contains potassium, so it is to be used in caution in patients with hyperkalemia or in case of severe renal failure. And because it contains calcium, it is incompatible with a blood transfusion. And because the presence of because of lactate metabolism occurs in the liver, it should be used cautiously in severe liver failure. Plasmalite is a balanced isotonic crystalloid uh, with a normal plasma electrolyte composition, and it is one of the most physiological IV fluids. It contains sodium, potassium, chloride, magnesium, acetate, and gluconate. And um, the main advantage is that it has a balanced electrolyte profile and a buffering system. Instead of the lactate, here it has acetate and gluconate, which will get rapidly metabolized in the muscles and the peripheral tissues, and thereby will help in maintaining the acid-base balance without causing any acidosis. And it can be used for a large volume resuscitation, perioperative fluid therapy, sepsis, critical illnesses also, because it does not causes hyperchloremic metabolic acidosis, which is seen with normal saline, and it does not depend on the liver, does not depend on any liver function like the Ringer's lactate. And it is associated with better renal perfusion and therefore less risk of acute kidney injury. And it also does not contain calcium, so it is more compatible with blood transfusion. And since because of the potassium levels, it should be used in cautiously in hyperkalemia. But and the another disadvantage is the cost. So 0.5% normal saline is a hypotonic crystalloid which contains 77 milliequivalents of sodium and chloride. And unlike this isotonic ones, once this is infused, it distributes not only in the extracellular compartment, it also shifts into the intracellular space because it is hypotonic relative to the plasma. So as a result, only a small volume will remain inside the intravascular space. Thus, it is unsuitable for volume resuscitation or in cases of shock. So its primary role is to provide free water replacement, especially in conditions like hypernatremia, where we need a gradual reduction in sodium levels. So it is more commonly used as a maintenance fluid, and it should be used cautiously because excessive administration can lead to hyponatremia and cerebral edema, especially in the post-op patients with increased ADH secretion. And it is contraindicated in head injury, traumas, burns, neurosurgical patients, etc. because the hypotonicity can worsen the cellular swelling and it will cause the more cerebral edema. 5% dextrose is an isotonic solution. It contains 5 gram of dextrose per 100 ml with a total osmolarity of 252. So when it is infused, this dextrose will rapidly get metabolized, leaving behind the free water, which makes it as a physiologically hypotonic fluid. So, and this free water will distribute throughout the total body water, and around one third, two-third will enter into the intracellular space, and only a small fraction in the extracellular compartment, making it a very minimal intravascular volume expansion, and is not suitable for a resuscitation. It's mainly used as a maintenance fluid and to prevent the starvation ketosis, and it's also used as a vehicle for drug administration. It provides a 170 kilocalories also, but it is a limited but it is a limited caloric support. It's not adequate for the nutritional needs. And it should be avoided in shock, hypovolemia, head injuries because it can worsen the cerebral edema because of its hypotonic effects. Hypertonic saline, here the sodium concentration is more than that of the plasma. The
One,
most commonly used is
one moment. 5% dextrose. What is the main advantage in post-operative setting as
it's
a
a
maintenance fluid?
maintenance.
Well, apart from the maintenance, what does it do? What is the advantage?
So it prevents starvation ketosis, sir. Provides nutritional
Like it prevent anybody else?
nutrition support.
It provides a daily requirement of calories, sir.
No, no.
No. How is it
Not
daily
all.
requirement? 170 kilocalories. How can it be daily requirement?
How many?
It
You
is
need
low.
10 liters. You need 10 liters. You can't give 10 liters of fluid. Even that will be insufficient.
Main advantage of anybody else can give the answer. So it mainly reduces prevention of nausea and vomiting. It is known to significantly reduce the incidence and severity of post-operative nausea and vomiting. And also it is proven to decrease the need for antiemetic medication post-op. And also it reduces catabolic stress by giving immediate calories. Although it is low, it helps suppress the body's catabolic stress response because of that. And it reduces the release of stress hormones like cortisol. And other thing, as you mentioned, it is serves as a maintenance fluid. Okay, continue.
So hypertonic saline. Here the sodium concentration is higher than that of plasma, and it contains about 513 milliequivalents of sodium and chloride with a very high osmolality. And because of this hypertonicity, it will draw water from the intracellular and the interstitial compartments into the intravascular space, thus causing a rapid volume expansion with a relatively small infused volumes. So this can be particularly useful in neurosurgery settings and critical care. So, and it is mainly used in case of severe symptomatic hyponatremia where it will raise the serum sodium quickly and will reduce the cerebral edema. And it can be also used in a case of refractory shock for rapid volume expansion also. But it requires strict monitoring because rapid correction of the sodium can lead to osmotic demyelination syndrome. And the complications include volume overload, pulmonary edema, hypernatremia, and local vein irritation.
No, you said
And
neurosurgical. You said neurosurgical, no emergencies. Why? Why is it used in them? What does it do?
uh, sir, it can cause the rapid volume expansions, and it can decrease the edema down.
That it works by creating an osmotic gradient, then which in turn draws excess water out of the brain tissue and helps in reducing the intracranial pressure and cerebral edema. So it basically draws the water from the brain tissue and into
Brain
the
tissue.
bloodstream.
Into,
Okay, yeah,
yes, sir.
and also in respiratory therapy.
Okay, sir.
How does it work?
That's great.
When inhaled via a nebulizer, how does it work? It helps patients with conditions like cystic fibrosis and bronchiectasis, where it pulls water into the airways to thin the thick mucus plugs will be there, no? So it
Yes, yes.
can be easy, that it will be easier to cough up.
Okay.
Okay,
Sir.
and other things, as you mentioned, shock resuscitation.
Yes, sir.
Okay.
So albumin is a natural colloid which is primarily for plasma volume expansion and oncotic support. It is available in different concentrations, most commonly the 5% albumin and 20 to 25% albumin. And albumin is albumin accounts for the majority of the plasma oncotic pressure. So when it is infused, it remains largely within the intravascular compartment, thus drawing the fluid into the interstitial space into the circulation. And albumin is used in hypovolemia when crystalloids are insufficient, especially in case of sepsis, burns after the initial resuscitation, in major surgeries, and in case of hypoalbuminemia with edema. And it can also be used in large volume paracentesis in cirrhosis to prevent the circulatory dysfunction, and in case of spontaneous bacterial peritonitis and hepatorenal syndrome. And unlike crystalloids, albumin does not cause any tissue edema, and thus it's useful in patients with third spacing. But it is expensive. It can cause fluid overload, pulmonary edema, and rarely some allergic reactions also.
What is the major?
Hypoalbuminemia you mentioned, no?
Yes, sir.
Sorry, sir. Heli. Hello? Sir, Heli.
What is the major problem with albumin, ma? Giving albumin, apart from the cost, which is 8,000 to 10,000 rupees for the 20% one and 4 to 5,000 rupees for the 5% one. It will only be present in the circulation for less than 24 hours. So
Less half-life, sir.
So basically, you are putting it down the drain. So the only two indications, as you said rightly, is the patients with the generalized anasarca with pulmonary edema, where the fluid needs to go into the intercellular compartment. By increasing the colloid oncotic pressure, it sucks the fluid from the tissue into the intravascular compartment, which then be excreted, so that it reduces the pulmonary edema and also anasarca. And second is hepatorenal syndrome. I think those are the two real indications. Others are all, physicians and intensive care indications, which are very loose. I don't think, when they don't know what else to do, they will give albumin. But it's of not much use because of the things that I said. It will only stay in the blood for 24 hours, so it's not going to cause any major advantages.
Yes, sir.
Okay.
So that is what I was coming to. You said hypoalbuminemia, no? In what
Yeah.
level of hypoalbuminemia you give albumin infusion?
No, sir.
Like, what is a normal level?
A normal level of albumin is 3.5 to 5 gram, sir.
Yeah, around 3.5. Okay. So
Yes.
the thing is, if it is 3, 2.5, 1.5, or less than 1.5, when do you give albumin? Usually,
Um, Less than 2.5, sir.
no. Less than 2.5, if you give, as sir mentioned, it will go down the drain. It has to be refractory hypoalbuminemia or albumin levels lesser than 1.5. Those patients, those are the patients who will have severe anasarca and refractory hypoalbuminemia. In those cases only, it will help. In other
Okay, sir.
cases, you need to improve the general protein levels by giving alternative sources of protein, not albumin.
Okay.
And remember, albumin levels are a indication of inflammatory process in the body. It's one of the good inflammatory markers. Um, it can also be a nutritional marker over a period of time, but more importantly, a pre-albumin is considered more of a more accurate nutritional marker. But albumin is an inflammatory marker used in especially inflammatory bowel disease, where albumin levels are used to see how well the inflammation is controlled or the patient is acutely inflamed by whether the cecum or colon or small bowel or whatever. So in any inflammation, yeah, albumin is a good inflammatory marker. Okay, carry on.
Hydroxyethyl starch. It's a synthetic colloid solution which acts as a plasma volume expander by increasing the oncotic pressure. It remains predominantly in the intravascular compartment, producing more sustained volume expansion compared to the crystalloids, and was used previously in shock, major surgeries, and trauma resuscitation. It is associated with increased risk of acute kidney injury and the higher need of renal replacement therapies and potentially increased mortality also. And it also interferes with the coagulation, leading to coagulopathy and increased bleeding risk. Coming to the maintenance fluid calculation, it is calculated
Just a
with,
minute, ma.
sorry,
Nikita, what is now the current accepted thing? Is it crystalloid or colloid?
So it's crystalloids only current accepted guidelines.
No colloids are used. If you have to use colloids, you can use fresh frozen plasma or blood products. Don't use any
Yes, sir.
colloids. Okay, right. Carry on.
the maintenance fluid calculation is calculated by the 4-to-1 rule. For the first 10 kgs, 4 ml per kg per hour. For the next 10 kgs, 2 ml per kg per hour. And for about 20 kgs for every kilogram, 1 ml per kg per hour. So, the fluid stewardship is defined as a series of coordinated interventions to select an optimal fluid, the dose, and the duration. And the 4 Ds are drug, dosing, duration, and de-escalation. The first D, the drug is that emphasizes that the IV fluids should be treated like medications, each fluid having specific indications, contraindications, and its physiological effects. So, the choice must be individualized rather than a routine. And the second is dose, which refers to the amount of the fluid administered. Both under resuscitation and the fluid overload are harmful. So the dosing should be based on the patient weight, the clinical status, and the ongoing losses with frequent reassessment. And the third thing is duration, that highlighting that the fluids should be given for the shortest necessary period, avoiding unnecessary continuation once the patient is stable or able to take oral intake, thereby to prevent the complications like edema and electrolyte imbalances. And the fourth D is the de-escalation, which involves actively reducing or stopping the IV fluids when it is no longer needed, or even prompting the fluid removal by the usage of diuretics or some fluid restriction in cases of fluid overload. And the recently proposed model for guiding the fluid therapy during the shock is summarized by a acronym called ROSE, that is resuscitation, optimization, stabilization, and evacuation. So the resuscitation. So in this initial phase, which is typically occurs within the first 3 to 6 hours, we restore the perfusion by giving the rapid IV boluses, blood if needed. Thus, to maintain the mean arterial pressure to maintain the mean arterial pressure for more than 65, the urine output should be more than 0.5 ml per kg per hour, and to decrease the serum lactate. In the optimization phase, this is a subsequent phase which occurs within a few hours and is related to the ischemia and the reperfusion. Here, the focus is to avoid the hypovolemia or the fluid overload. In the stabilization, here the stages in this stage it is mainly characterized by the absence of shock or any imminent threat of shock in the following days. So the focus will shift to the organ support, and the therapeutic goal is the late conservative fluid management. Keep minimal fluids, and enteral feeding is more preferred. And in the evacuation phase, the patient will enter the flow phase, which is characterized by the uh, um, spontaneous elimination and excretion of the previously administered excess fluids with the help of diuretics or fluid restriction, or in case of severe overload, even dialysis. So this is to improve the pulmonary edema or some abdominal compartment syndrome, etc. So the management of the patients in shock is based on these four rows phases of fluid therapy, which, when excessive, can lead to some deleterious effects and can contribute to some adverse clinical outcomes, such as prolonged invasive mechanical ventilation, extended hospital stay or ICU stay, and the need of uh, dialysis or increased risk of mortality. That's it.
Okay. Any questions? All the students have been silent.
No, sir.
Anything? Questions? Okay. Your comments, Nikita?
Nikita, comments. Have you
Hello, sir.
muted yourself?
You're there? Okay.
Comments,
Oh,
Yes, sir.
comments.
Sir,
okay.
her slides were all very informative, sir, and she did not read the slides. And the values she provided, like the correction values, that is the most important aspect. She explained that part well, sir. What exactly dose we have to give and how we have to give the routes, doses, and timings. Yes, sir.
Okay.
She did a very good job, sir.
Okay. Sanya?
So very well presented. Extensive topic. She explained everything very well, sir.
Karthik?
It's a very good class, sir. Like these are the basics which we don't concentrate much, but a very important class for everyone to know.
Sir?
I think both of Mahati and Malavika, I think you have done exceptionally good job. This is your first presentation, and the slides are very good, and also you didn't read from the slide. You have talked very, and you explained the slides very well, and the information that is given is up to date and precise. So it's very good. Well done.
Yeah, I agree with sir totally. And since it was a first class, it didn't look like for your first class. Your presentation was precise, and slides were also like exactly having 5 lines. You're not gone overboard with filling the entire slide with many lines or many words. So you're stuck to the basics of presentation and presented very well as well.
So I
If n-
think one last this one to all of you. See, after the antidiuretic hormone effect and the other effects in the third, fourth day, the excessive fluid that is being transfused either by the anesthetist during surgery and after surgery in the post-operative period, and the patient who are taking orally, the urine output will increase because the ADH effect will be gone and patients will get rid of all the excessive fluids. So in that phase, you don't have to chase the urine output and keep giving them excessive fluids. As long as they are drinking orally, as you said, de-escalation is the mantra, not chasing the urine output. Only if the patient is dehydrated and not taking enough orally, then you give them maintenance, because don't chase if they are passing 3 liters or 3.5 liters. You don't have to give excessive fluid. So I think it's fluid therapy has to be monitored every day, and intra-day also, so that you have to be either optimum or under rather than over. because over has so many ramifications. As I've already told you, pulmonary edema, deep vein thrombosis, tissue edema, bowel edema, all of these have deleterious effect in the recovery of the patient. I think you have done a good job, ma. Well done.
Thank you, sir.
Okay, if there are no more
Thank you.
questions, I think we'll conclude.
Thank you, Niranjan.
Thank you, sir. Thank you. Thank you, everyone.
Thank you, sir.